early intervention with children who are pre-lingually hearing impaired, and about the services that are available to them, some legal aspects that are related to those services, as well as the decision-making process about selecting educational and communication modalities. So we kind of have a lot of information this week, but it's all related. Let's talk about where we've been and where we are now. Prior to the late 1970s, education of children with hearing impairment was primarily at residential schools. So kids were shipped off to basically a boarding school that was specifically geared towards catering to children with hearing loss. Unfortunately, most of those programs did not provide much diversity in terms of the curriculum, in terms of the communication modalities. It was sort of a cookie-cutter, one-size-fits-all approach. And so whether you were a child who was profoundly deaf, or whether you were a child who maybe was only mildly to moderately hearing impaired, the communication modalities and the curriculum were identical. You probably learned sign, because this was back in the day before we had a significant emphasis on oral or auditory verbal communication. And so we did a pretty crappy job, to be honest. Didn't necessarily meet the needs. And this continued despite the fact that as early as 1965, the Babbage report pointed that very thing out. Those very problems, that we can't use a one-size-fits-all, a one-approach-fits-all programming for children with hearing impairment, because there are different severity levels, there's going to be different needs. So as a result, they said that we also were doing a really poor job of identifying children with hearing impairment early enough, and that as a result we were losing out on some critical time to institute interventions. And so they came up with, as a result of that report, the federal government had an ad hoc committee, and they came up with what they called the high-risk registry. And they began pilot studies. And basically what this did was, it was a primarily pen and paper screening process designed to identify babies who were at increased risk for possibly having hearing loss, and so we need to monitor them. So, for example, if you gave birth to a baby, a nurse or a volunteer is going to ask you a series of questions about family history. They're going to record medical data. What was the child's APGAR scores? What was their bilirubin levels? Were there congenital abnormalities of the face, the ears, the head and neck? And a whole series of kind of red flags that place a child at potentially increased risk for having a hearing loss. And so what they did was, using this pen and paper screening, tried to identify the children who would be at most risk, and then try and screen and assess them early and often. And that pretty much continued as the primary method of identification through the 80s. I can remember when I was in graduate school back in the mid-80s, and we would get referrals at the hospital, we were the patient hearing department for the university hospital, we would get referrals from either the high-risk nursery, the NICU, or from the regular nursery on babies that were identified as quote-unquote high risk. And we would have to go in and do hearing screenings on them. And if they passed, then there was one protocol that was followed with follow-up. If they referred, there was a different one. But that continued, and they finally took a look, 21 years later, at the data. So they had a lot of data. You think about how many kids were born between 1967 1988, a lot. And what they found was that we were still doing a really crappy job of identifying children with hearing loss, and that the average age at identification was 30 months, more than 30 months of age. So these kids were close to 3 years of age on average when they were identified. That means that we dropped from just over 3 years of age at time of identification back in the 60s to just a little bit under 3 years of age in 1988. Not a glorious success story. So, the Surgeon General, who happens to have just passed away, Siever Koop, saw that in the news, he passed away either yesterday or early this morning, so news to hear anything about it. He actually set as one of his goals that by the year 2000, we would be capturing 90% of children with hearing loss by 1 year of age. That was his goal. And so, to help facilitate that process, the National Institutes of Health jumped in. So we've got now the National Institutes of Health, we've got the Ad hoc Committee on Hearing Loss, the Commission on Deaf Education, the Surgeon General, all these people coming together, and they said, how we're going to do this is we're going to do universal infant hearing screening. Forget this whole high-risk registry as the flag. We're just going to test all babies. What do you think about that? I think it's universal hearing screening is a good idea, bad idea, cost-effective, not cost-effective. Any other opinions? Anyone question the allocation of resources to do that, to screen every baby? No one thinks it's a bad idea? Well, I will be honest with you and tell you my bias. I think it's a great idea. And here's my reason why. When babies are born, they are typically put through a battery of screening tests. They have blood drawn, and they test that blood for about a gajillion plus 3 genetic syndromes and medical conditions. Guess what? The vast majority of those we have no treatment for. We cannot alter the outcome. All we can do is educate the family and let them know, oh, by the way, your child has this horrible disease or this horrible condition, and this is what we can expect. So, we're screening for very low incidence conditions for which we have no effective method of treatment. hearing loss is a relatively high incidence condition for which we do have available treatments and which the outcomes are dependent upon immediate intervention. And the earlier that we intervene, the better. So I would say there's absolutely no legitimate argument not to be doing universal infant hearing screening. So, running at the speed of US government, 6 years later, legislation was passed. And the US government officially endorsed the idea. Of universal infant hearing screening. Thankfully, some states took the lead and didn't wait for the federal government. And why they didn't start kicking and screaming and taking the states to court over this, like they have been over immigration and other things that the states are taking the lead on, that the federal government's not taking the lead on, I'm not sure, but I think it's a little bit harder to necessarily say that you're going to protest denial of services to babies. But anyway, so several of the states started implementing their own universal screening programs. But by 2005, only 28 of the states and territories, and you should be aware that when we're talking about federal legislation, it doesn't just affect the 50 states. It also affects all of the territories and all of our overseas possessions. So Puerto Rico is a territory. It's a commonwealth. It's affected. The U.S. Virgin Islands. Some of our Pacific Island holdings, Guam, and some of the other places that have ties to the U.S. These laws also affect them. So as of 2005, only 28 states and territories had implemented universal infant hearing screening. In those states, the age of identification dropped down to 2 to 4 months. Can you spell S-U-C-C-E-S-S? Yes, we can. It was a raging success. In the states where they did not have legislative enforcement of universal infant hearing screening, the average age of identification was still sitting right around at 30 months of age. So, let me ask you, room full of prospective maybe Sunday mommies in here, if you knew that there was a test that could be done to provide services for your baby if he or she has a hearing loss as early as 2 to 4 months of age or waiting until they're 3 years of age, which option would you choose? Hopefully the early intervention option. So, anyway, we had some continued growth and enforcement of these programs, but again, not all of them were officially legislated. Some of them were just endorsed. So that by 2008, our EHDI is Early Hearing Detection and Intervention. Early Hearing Detection and Intervention, EHDI. Early Hearing Detection and Intervention programs were given a grade of B. So here in the U.S., our EHDI programs got a grade of B. That's not bad. Great. What's the minimum cutoff for an A range grade? be an A minus, but it's in the A range. And what was our goal? Set that right out in the coop, 90%. So by 2000, and obviously by 2008, we were still sitting at a B. So we didn't make Dr. Coop's goal. In 2010, we now have 45 of 50 states and multiple territories are now legislating universal infant hearing programs. Yay, good deal. And Ohio, Kentucky, and Indiana, our tri-state area, are amongst them. Actually, Kentucky was the first, believe it or not. I know a lot of people. I used to live in Kentucky, and I'm not embarrassed to say that. There were a lot of people who were surprised to learn that. Kentucky was very cutting edge when it came to care of infant hearing. But anyway, as of 2012, we are still sitting at that 45, so we still have a lot of work to do. Because again, the statistics are holding true. If the child is born in a state with the universal infant hearing screening program, they're identified typically no later than 4 months of age. If they are in a state that does not have it mandated, they are likely not to be identified until closer to the age of 3.
What are the 5 states that don't? You know?
What's the process?
What are the 5 states that don't?
Oh, you know what, I don't recall. I can look that up. Will you send me an email to remind me to do that? I'm trying to remember. I remember that there was 1 or 2 that kind of, I was like, really? But, yeah. And I haven't updated this for 2013, so there's a chance that maybe that number has shifted slightly, but not a whole lot's been happening with state and federal governments lately. They're bickering back and forth at each other and fighting over who's going to pay for what and why, so. But anyway, the bottom line, what I want you to take away from this is that we have seen this shift from the 70s and before to primarily the one size method fits all intervention paradigm, and that's basically you send the kids away to boarding school, to a school for the deaf, whether they're deaf or hard of hearing, and not identifying them until they were significantly older, to now we are at a point where we're getting close to identifying roughly, not quite, but we're getting close to almost 90% of kids with hearing impairment by 4 months of age. And if we go by the year of age, we're definitely above 90. We're not quite as good as we can get. And the interventions have moved from an residential educational based to more of a family-centered, home-based program of early intervention, and then we make the decisions about communication modality and educational venue when the child transitions out of early intervention at the age of 3. Because the early intervention programs are designed for birth to 3. And then at age 3, a transition meeting is held, and the child is typically channeled into programs through the public schools. And I am much more familiar with the process and the services in Kentucky and in Indiana because they have the same program, and I've worked in it. I have not worked in Ohio's program. I understand it, but I've been in those transition meetings, and been involved in those discussions and helping to get the kids placed. Here in this area, if the child is going to transition and the family wants auditory verbal as opposed to a manual or sign educational option, they basically have two choices. They go to St. Rita's and they get manual communication, or they go to Ohio Valley Voices, which is a private school as well, and it's totally auditory verbal, or they go into the regular public schools and they just get supplemental services. There are not very many hearing impaired self-contained classrooms in the local public school districts, and so what they may get is some pull-out services in a special ed room, but not necessarily a hearing impaired program. In northern Kentucky, they actually have a satellite of the Kentucky School for the Deaf at one of the elementary schools in Mitchell. And so they actually bring kids from all over northern Kentucky can get free public education at the school at River Ridge, and they have self-contained classrooms, and they're categorized by level of impairment. So you may have one classroom that's profoundly hearing impaired, and they're using manual communication. You might have another room where all the kids have cochlear implants, and it's all auditory verbal. And then you might have another classroom where you have kids that have mild to moderate or moderate to severe loss, and they're using total communication, which is really kind of cool so that you have all the options available. But not every place has that. We don't have a Southern Ohio School for the Deaf or a Southwestern Ohio School for the Deaf. And that's unfortunate because then it's up to the individual schools to implement some of those total communication programs. So if you want manual, you go to St. Rita's. If you want oral, you go to OVB. And unfortunately, OVB stops after the 3rd grade because their goal is that the kids will have the auditory and verbal skills necessary to be mainstreamed by the time they hit 4th grade. And so if they are not, and their success rate is pretty good at that, I have to admit, but if they're not for some reason, then those kids are going to be sent into the regular public schools, and they're not going to have the same level of support and services available. I think I told you guys that my son's teacher's son got meningitis right before he turned 2 and became deaf, and he had bilateral cochlear implants put in, and they're still fighting over services at this point because he has been at OVB and the state early intervention program was paying for it, and when he turned 3 back in the summer and transitioned out, he became the responsibility of the public schools, and they didn't want to pay for those services, and what they were offering was ridiculous in terms of, but anyway. So know that we've transitioned, we've made a lot of progress, absolutely, but we still have work that needs to be done. Yeah, you had a question.
Oh, yeah, I was gonna ask, what's the reason that these, are they resistant to
I don't know that it's flat out resistant. I think it's more an issue of there are other priorities that are taking precedence. As bad as things are, we hear, at least here in the Midwest about the economy, and the states are struggling in their budget crises, and everyone's in the red, and they're trying to shift and allocate, and that's why we have casinos opening all over Ohio now, because they're trying to generate an alternate form, and they're just shifting the money from one bucket to another is all that happens when we do stuff like that. But at least in my organization, generalizations without saying that, but money's got to come from somewhere. And anyway, I think that it's a matter of for some places, do you take money away from food programs to provide supplemental food for families or in order to pay for programming designed to early identify hearing problems? I can understand, even as important as it is to me, I can understand if I were a legislator and that's what my decision was, it would be hard. I'm not saying I agree with it. I think it's terrible, and I think it's terrible that it comes down to those kind of choices at times, but it kind of is. So I don't really think it's like open hostility or resistance to it, so much as I don't think we've necessarily done a good enough job of showing what the cost savings could be, that maybe it's worth it to allocate the money from somewhere else now, because we're going to save it down the road, and we definitely will, because the child should hopefully not need services across such a lifespan. But good question. Someone else I think had a hand up. Yes.
Does Ohio Valley Voices now have like a screening process that requires them to be certain
Oh, absolutely. But they're you have to remember, schools are classified by the grades that they provide, the services that they provide, and they are only K through 3 certified. So if the kid, because and that was by design, because their goal was that by the end of 3rd grade, these kids were ready to bump out into 4th grade, ready to get their peers. And unfortunately, things can sometimes happen and the kid may not be completely ready. So they can still come there for supplemental services and everything, but it's going to be out of pocket, beginning from the very beginning. It's out of someone's pocket. It's either going to be out of the local district pocket or out of the parent's pocket, because it is a private program. Questions about the transitions that have happened from back in the Stone Age to now? All right, so what are some of the risk factors for hearing loss? They can be divided into broad categories: maternal infections during pregnancy, maternal ingestions during pregnancy, birth complications, defects of the head, neck, ears, and face, genetic conditions associated with hearing loss, or family history. So, maternal infections, things like the CMV, cytomegalovirus, is associated with fetal loss. Rubella, or German measles, is associated with fetal hearing loss. Yes. Cytomegalovirus. I'll blurt it out. I'll send a spelling out. Cytomegalovirus. It's not very pleasant. Rubella, which is German measles. There's a huge outbreak of German measles during the early to early latter part of the 1960s. So basically 63 through like 67, and there were a lot of pregnant women got it, and so there are a lot of people my age, I was born in that time frame, who were born with hearing loss of varying degrees because of mom's exposure to rubella. I can remember in my high school, there were 3 guys that I personally knew, there may have been more, but there were 3 that I personally knew who had hearing loss related to their mom having had rubella, and the toxoplasmosis. Those are the three most common maternal infections that are associated with fetal hearing loss. So CMV, rubella, and toxoplasmosis. Another significant risk factor are maternal ingestion of ototoxic medications. And there are a lot of things that are ototoxic. Even aspirin is ototoxic. And if you watch TV at all, at least one commercial in every commercial break is for some sort of pharmaceutical. And so at least during every half hour, there's going to be at least one medication that they mention, and one of the side effects is sudden loss of hearing or vision, or if you experience changes in, because there are a lot of medications that are ototoxic. Aspirin is a biggie, and it's frequently prescribed to women who are pregnant who have clotting issues, because it's safer to give them aspirin than it is to give them things like warfarin, Coumadin, some of the Plavix, some of the others, which can really cause, say, if you are pregnant or think you could become pregnant, or nursing or pregnant mothers should avoid, and it's because so many of these medications can affect the baby, not necessarily just hearing, but can have a dramatic negative impact. So lots of things that mama takes can potentially impact hearing. So then there are birth complications. So these are things that we look for, and that because we still do a high-risk registry, even though we universally screen everyone, we will still check off any of these things that that may be at play, because that just increases their risk. And so even though we have a kid who maybe passes their newborn screening, if they have a risk factor or multiple risk factors, we're going to do more diligent follow-up with them. We're going to have them come back. We're going to rescreen them periodically just to make sure that they don't have a potential progressive condition. So things that we look at are postnatal infections. Maybe mom was asymptomatic, and now after birth we discovered she has CMV, or herpes, or rubella, or toxoplasmosis. I saw some looks, and you've not lived until you've gone into the NICU and you have to use airborne and contact precautions because the baby has herpes zoster oticus, which is herpes of the ears, because he got it coming out the birth canal because mom was in the midst of an active episode. I think we can just do a C-section because that is beyond me, but I'm not cooking, so it's not my call. And I've had that where the kid had been exposed to CMV, had herpes zoster oticus because he got the herpes virus. So it looks like a cold sore, except it's all over the ears. What else did that poor kid have? There were like 4 different things going on, and I was like, this is a mom who should have her license to be a mom revoked. I say that as an adopted parent. If you knew how closely they looked at our kitchen and what we had to go through to prove that we were fit parents, and then any Joe Schmo and Jane Doe can get it on in a back alley somewhere and give birth to a baby and expose them to multiple STDs and other things, I'm thinking, there is something truly horribly wrong with this picture. But anyway, so prenatal, postnatal infections. We'll look at low birth weight. If they weigh less than 3 pounds at birth, that is a high risk. Did they require ECMO placement? ECMO is where they are put on a machine that actually mechanically drains their blood, oxygenates it, purifies it, so it takes out, basically like a dialysis type of thing, but also oxygenates it and puts it back into them. So it's like a heart-lung transfer machine. And I honestly at one point knew what ECMO meant, but I can't remember. It's something cardio, something oxygenator, anyway, metabolic maybe. But anyway, they're put on a machine that basically cleanses and nourishes their blood. Do they have any kind of a neurodegenerative condition? Have they been diagnosed with neurofibromatosis 2? Do they have Wardenberg syndrome? Do they have CHARGE? Do they have Usher? They may have some sort of a degenerative condition. Hyperbilirubinemia or jaundice, extreme jaundice. That is something that affects the liver, can affect the blood vessels, and that can have an impact on hearing.
I just had a question. I did the neurofibromatosis too, and it was saying that only 50% are because of the maternal diseases. So would there ever be like a concern to test for that, since it would that be something that would be tested in like normal history, or would you wait for symptoms to?
Oh, for NF itself,
Yeah.
there is a gene for it, and so I think it is one of the conditions that they'll screen for, but they don't always identify it. That's the problem. So it's only about 50% of the time can we identify through the blood work, for example.
Because like the NF1 had like physical symptoms with it, but the NF2
Right, until they start developing the tumors. And that's the problem. The screening for it is not great, and 50% of the time they're asymptomatic until they're suddenly symptomatic. But my cousin has 2 daughters, one of whom has it, and one who doesn't. And I know that she is still tumor-free, but they've known since when she came home from the hospital. So I know that they do screen for it. But anyway, not the most effective. Please go.
So, I agree with this.
Yes.
Will it go away?
It can. They will often treat it. Light therapy is very effective at helping to break down the excessive bilirubin. So they will often put the babies under. They have their little tanning bed. They put the little goggles on them, and they typically try and turn them regularly. We get overdone one side or the other. But yeah, it does. There's something about the exposure to the UV light breaks down the bilirubin and helps. And they can use medications. If they required a NICU stay for any reason whatsoever, they are considered at high risk. If they have respiratory distress or hypoxia, reduced oxygen levels, so if their O2 saturations, they have problems with that, then they're going to be considered at high risk. And, or if they have ototoxic medications. Any drug that ends in statin, any drug that ends in mycin are notoriously ototoxic, and their use has to be very closely monitored if one cares to preserve hearing. Now, sometimes we have no choice. the doctor says to you, Ms. Pavlovek, do you want us to let your baby die, or would you prefer that we give your baby this medication, and it may very well result in your baby being deaf or hard of hearing? Chances are you're going to pick having the baby get the medication. But the nice thing is we can actually now monitor and do testing that we can hopefully give them a heads up and perhaps make slight titrations in their dosage and minimize or even eliminate the risk for hearing damage. We have a couple of patients that come here to our clinic that we do periodic ototoxic monitoring on because they're getting long-term chemo for different conditions, and so we do otoacoustic condition testing and hearing threshold testing repeatedly to monitor and then provide that information. And you see that sometimes physicians will adjust their medications. We have ways of intervening. Obviously, if they have any defect of the ear, head, or face, skin tags, ear pits, cleft lip or palate, hand palate. So if they have any, abnormality, because those structures of the ear are forming at the same time as the other structures of the face, and so if something has interrupted that process prenatally and caused problems, there's a very good chance that there could be issues with the ear. Genetic conditions associated with hearing loss, we talked about a couple of those. There are others, Treacher-Collins, Pierre-Robin, Cruzon, Down syndrome. There's a lot of different conditions, genetic conditions, Ortenberg syndrome, Klinefelter syndrome, lots of them. And then if there's a family history of childhood hearing loss. So those are things that we're going to be concerned about. Whether they pass the newborn screening or not. If they pass and they've got risk factors, we're going to see them back again. I usually like to see them at 3 and 6 months of age. And if they're okay then I usually say bring them back right around their first birthday so that we can have these results for the pediatrician for their 1-year-old checkup. Then I feel pretty comfortable. Unless it's a condition that we know has an onset potentially later, then we're probably not going to be checking them as often early as we would later on. Okay? So, the Joint Commission on Hearing came up with some goals, and their goals were that all infants be screened by 1 month of age, preferably prior to discharge from the hospital. A couple problems with that goal. First of all, how long are most mommies and babies in the hospital after birth? Less than 24 hours. Basically, childbirth, uncomplicated childbirth has become an outpatient procedure. So, yeah, I can remember, back in the day, my mom looked forward to her 5-day respite in the hospital. So yeah, they was in the hospital for 5 days, which was ideal because it typically takes between 48 and 72 hours for the mucus and fluid plugs and buildup in the ear canal to dry up and come out completely. So if we are screening these babies before discharge, and the majority of them are not there for more than 24 hours, guess what's happening? We're identifying potential hearing loss in a lot of babies that have perfectly normal ears, they just have clogged ear canals. So what we have seen is a fairly consistent over-identification or over-referral of infants. And so then they come to the audiologist because they have to, most of the time, this testing of newborns is done by nurses or by volunteers in the hospital. And the test is an automatic and it says they pass or fail. They pass or refer. They don't ever say fail. They just say refer. They don't ever say, sure, your baby failed the hearing test, when in reality it may not be a fail at all. It's a matter of baby had funk in his ear canals that the sound from getting through. So they always just say refer. We're going to send you to the audiologist. But anyway, so that's the big problem, is that now that the hospital stays have gotten so short, it was great when they still had like 2 to 3 days because we were seeing much lower referral rate then, and I think we were more accurate, whereas now we're seeing a significantly higher referral rate, and yet when we get them in for the follow-up, they're testing just fine. But anyway, so that was one. The other thing is that any infant who refers positive, screens positive or refers, has to have a complete hearing test within 3 months. So they get them some time. If they are identified with hearing loss, intervention should start prior to 6 months of age. Any infant with late onset or progressive hearing loss is going to be identified at the quote-unquote earliest possible time. That's like reasonable accommodations, or yeah, I mean it's a garbage generic term that really doesn't mean a lot. The other thing that they wanted to see happening was that any infant with hearing loss is assigned to a quote-unquote medical home as determined by the American Academy of Pediatrics. AAP is American Academy of Pediatrics. Sorry. So what is a medical home? Go for it.
Is it like one doctor who oversees and coordinates all the
One doc, one healthcare provider is basically the gatekeeper or the case manager for that child. Absolutely, you are correct. There's a reason why you're only going to be here for about another 8 weeks. Now I've just instilled fear into you. 8 weeks. It's funny how when you first get here, you're looking forward to that light at the end of the tunnel, and then suddenly you're starting to see that light at the end of the tunnel, and you start having palpitations that perhaps the runaway train is going to roll you over. Am I right? Kind of getting there. Holy crap! You guys went around on Friday to see the folks come in for the interviews. That was a fun process. That was this past Friday.
Can you repeat what she said?
Wait.
Can you repeat what she said about the medical home?
Yes, it is where you have a physician or other healthcare provider who serves as the case manager to oversee, or the gatekeeper to oversee and manage all of that child's care, including the hearing loss, so that everyone's on the same page, so that you don't have one physician managing their asthma and one physician managing their hearing loss, and that you have one person for whom all of their services are coordinated. HDI, so early hearing detection and intervention. Okay. So, this early hearing detection and intervention program starts off with the screening. And if they refer, they're sent on for diagnostic testing. So if they don't refer, they drop out of the system. If they refer and we do the testing and they are fine, they drop out of the system. But if they are confirmed to have a hearing loss, then they move into the intervention programs. Okay? And those intervention programs have 3 phases, and we're going to talk about those. But the screening process, like I said, is typically done by someone who's not an audiologist and uses automated ADR or automated photoacoustic emissions. There's 2 different types that can be done. For the prospective audiologists in here, they're transient photoacoustic emissions versus distortion product photoacoustic emissions. So, the potential speech paths don't very much. Photoacoustic emissions. If the child fails, they get referred on. They pass, they drop out. And for the diagnostics, we can do a threshold ABR, diagnostic OABs, typically do earlier testing, and we might do sound field testing with tones and noise and speech. Okay. So, that will then get them to the intervention portion of the early hearing detection and intervention program, so the final portion. Earlier is better. That's been our goal from the early 60s to now, is get them identified as early as possible. And this is when, as soon as they're identified, confirmed, that's when we try and establish the medical home. Is it going to be the ENT? Is it going to be the pediatrician? Is it going to be the family doctor? Whoever it is, that person's identified. And from there on, all communication goes through that medical home to coordinate care. Then we're going to implement their early intervention program in their 3 phases, and then at the end, as they transition out of that early intervention program, we're going to assess the outcome. Okay? So phase 1 is what happens immediately following diagnosis. Okay? And ends with basically the thinning of amplification. So this phase is typically relatively short. Our goal is to figure out what we're going to do in terms of access to sound. Maybe it's hearing aids, maybe it's a cochlear implant, maybe it's none of the above. But it goes until the decision is made and implementation takes place with any sort of amplification. During this time period, there's also a lot of parent education and support going on. And there is a great website, johntracyclinic.com. It's John Tracy-Clinic. It was established by the parents of John Tracy, who was an individual who was identified with hearing loss, and the parents were wealthy enough and they were able to obtain lots of resources, and they began parent support groups and training. So there's a lot of really good materials if you're going to be doing any kind of parent intervention work. I would strongly suggest that you check out that website because a lot of the stuff is downloadable for free and really good information. So anyway, at this point, we're just working on what kind of amplification or what kind of access to sound are we going to have, and kind of educating and counseling and guiding the parents through this process. There's a grieving process that parents are going to go through because this changes their entire outlook. Granted, in this day and age, with the access to cochlear implants, kids with hearing loss and with good hearing aid technology that's there's even if they're not deaf, if they're just hearing impaired, kids that are early identified pretty much, other than certain occupations where having absolutely normal hearing is essential, like air traffic control or something like that, they can pretty much do whatever they want to do, unlike earlier ages. But it's still a process that the parents have to go through, and this phase 1 really helps them get on that road. Phase 2 begins from that time of fitting or that time of activation, if they're getting a cochlear implant, for example, until the time that they have become fairly fully well adjusted to whatever that system would be. So the parents are going to learn how to take care of the hearing aid. They're going to learn how to troubleshoot things that you did. Typically, we'll provide them, most of the hearing aid manufacturers and the cochlear implant manufacturers will provide you with a parent kit that has all the essential things in it that they need. So they bring you a stethoscope, a battery tester, cleaning tools, dehumidifier, all kinds of things, anything that they could possibly need. And then they're trained to troubleshoot, and if they have hearing assistive technology, maybe they have an FM system, maybe they have alerting systems, things of that nature. They're going to be trained to do all of that. Okay? So this is a process that typically is going to take place, hopefully, within a month. But I have seen this phase last for months and months. I've seen this phase not end because there are adjustment issues. So, but phase 2 begins after the fitting or activation of the cochlear implant until they've had this initial adjustment period. Then, beginning at phase 3, that's when communication strategies really begin. And this is where we do parent intervention. We teach them strategies to improve and facilitate listening skills. And we do either or both clinic and or home-based formal early intervention, where we're going to be working with the child and the family together. So you may have you will typically see some separate parent-only interaction, and then you will typically see a conjoined parent-child interaction going on simultaneously, where you're actually training the child, but also demonstrating so that the parents can continue and provide ongoing intervention when you're not there. Because most of the early intervention programs anymore, you're probably not going to get more than about 2 to 2.5 hours a month with the kid, spread out over the course of the month. So you might get them like 45 minutes 3 times a month. The cutbacks are pretty significant in what the early intervention programs will provide. Okay. So Ohio's early hearing detection and intervention program has 10 regions. So the state's divided into 10 different regions. Here in southwestern Ohio, we are region number 4. And the office for region 4, I believe, is in Centerville. No, it's in Bonesville, which is over by Batavia, east side, Claremont County. In any case, so what happens is, let's say you have a child who refers on their newborn screening, and you take them to the audiologist for their follow-up, and a hearing loss is identified. At that point, you should be referred to your local early intervention regional office, and they will do an intake and get the ball rolling to help provide services. Any child who is to receive early intervention services does have to go through an assessment process, and they have to have their eligibility determined. However, by virtue of diagnosis, there are certain conditions that will automatically qualify, and the assessment is not really to determine eligibility, but rather to simply set goals. For most kids, it's going to be to set those goals if they qualify, so it's a contingent. But hearing loss is one of those automatically qualifying conditions. If they have hearing loss, they're going to be accepted into the program, so the assessment process is simply to determine goals. Okay? So we have these regional offices all over. In Ohio, our program is part of Help Me Grow. In Kentucky and Indiana, it's called First Steps. And Help Me Grow serves birth to age 3. It is jointly federally and state funded. And they have what's called a family share plan. And so what happens is, if you have insurance and you opt to not allow your insurance to be billed, then based on your income, you will have to pay out of pocket a percentage of the costs of the program, with the rest being paid for by state and federal dollars. So, and that used to be you could opt to not have your insurance billed and the programs would pay for it. But now, because of budget cuts and everything, they just can't afford to do that. So now, if you have insurance that will cover it, then they prefer that you allow the program to bill your insurance. And if you choose not to, then based on your income, you will be billed for the service.
Why would you want insurance?
Because some insurances have lifetime caps, lifetime limits of benefits. And if you think about, if you have a newborn with hearing loss, and you think about all the things that they might have to cover, repeated, physician visits, maybe surgeries, maybe hearing aids, maybe a cochlear implant, all those things, you may want to go off. But with the changes in healthcare law, where they're going to, at least theoretically, they're supposed to be doing away with those lifetime benefits caps, or requiring the family share plan without that's the primary reason that we choose
Can you give on the two separate family shares and
Yes. Family share is the process where if you have insurance that will cover the services that Help Me Grow or any of the other early intervention programs are providing, because it is a joint federal state program, their preference is that you use your insurance and not take, basically don't take money away from people who have no other resources, is what they're saying. And to incentivize you to do that, they're saying you can choose to opt out of the insurance part, but if you do, then based on your income, your family income, you're going to have to pay a portion for the services. So let's say that the kid needs OT, PT, and speech therapy. They have some condition where they also have hearing loss. And those visits are billed at roughly let's say $80 a visit. Okay? Well, if you have insurance that will pay $60 a visit, then Help Me Grow says you should allow us to bill them, and then we only have to pay $20 a visit for those services. And if the parent says, no, I don't want you to bill my insurance because I want to save this money because they may need it later, then Help Me Grow says, fine, let's look at your income. Oh, you make a family income of $120,000 a year. Guess what? Then you're responsible for that entire $60 that insurance would have paid. Or, oh, you've only got a family income of $19,000 a year and you have 5 people in your household. You don't know anything. Okay? So, the services are provided in the community. It may be in the home, it may be at daycare, it could be Head Start, anyway, any community-based setting. They also provide case management services, so they help you navigate through. And again, you have to go through that qualification process, and that's either done by diagnosis, some of which automatically qualify for by meeting criteria of the evaluation. There are specialty programs for hearing, there are specialty programs for speech and language, and there are specialty programs for vision, occupational and physical therapy as well as they also have developmental interventionists who are early childhood education specialists who kind of cross over all of those modalities. And I'll be honest with you, frequently there is a shortage, particularly of speech therapists for the early intervention programs, and so oftentimes if a child needs speech and language services and there is no speech pathologist available, a developmental interventionist will provide those services because they do receive specialty training in speech and language. Remember back to 223, there were a lot of special ed and early education majors in there with you. That they're going to get that input. Okay. All right. Let's stop there. We'll go through outcomes and communication modalities next time.
What up, Tyler? Huh?
I'm broken.
Broken?
Yeah.
Oh, what happened?
I have a genetic nerve disease, and I slept on this wrong. If I type like this, or if I type like this, I have to stop like every. I have to talk to that like this. Sorry.
You could get a scribe. I'm gonna type for you.
But my brain doesn't work like
No, I mean like somebody could come and sit in class and take notes.
well, I mean, I can write. Like, I write. Like, these two are the fingers that can't move, but I can actually write without moving. So writing is the problem, so it's actually typing.
See you later, buddy.
So I can actually write like this anyway. So I don't use this finger though.